All right. All right, as you guys continue to grab food and get settled, we're going to start the introductions. We want to thank everyone for joining us. I think there'll be people that kind of come in and out throughout these next couple hours of presentations, so bear with people dealing with their clinical duties still. We thank all of you for joining us and for all the hard work that the residents did this year. It's very impressive, and we can't wait to see how the presentations come out. There are a total of 7 presentations ahead of us. Each one will be timed, so you guys have a max of 10 minutes, which includes your 2 minutes of questions. Other than that, Mel will be doing the timing, so we'll kind of give you a 1-minute warning when you're getting close. This is a judged process. So the winners, the group that wins this, it does have some book money associated with it, so you do want to kind of come up and give it your best. We have one guest judge, Dr. Tyler Anstead, if you want. He's in the Department of Internal Medicine, and he'll be helping us decide the winner, or the winners. Thank you so much for your time. I think this is our 4th year in a row, so it's really exciting to kind of see how this has evolved and what the projects have turned into. Yeah.
So I just have one comment, too. I know a lot of you guys have been frustrated this year with your projects and just feeling like it's really hard to move the dial forward. And I guess to give you all perspective, and we told you this at the beginning of the year, but when we gave you a selection of topics, it was topics the QI committee's been struggling with. So it was meant to give new eyes on a project and new life to things that we struggle with routinely here at this university and in our ORs. So it's okay, and you guys should feel really good about moving the dial at all, because it's a huge accomplishment. These are tough issues that you're going to be tackling. First group.
All right, we're going to call up our first group that looked at blood product inventory. Group 1 wants to come on up.
Can I just go whenever? Cool. My name is Tom Galvazian. I'm here to present the Blood Product Inventory Management QI project. So our blood bank tracks waste of blood products on a monthly basis. One of the categories of wasted blood products includes ordered but not given. This indicates that a certain blood product unit was ordered for at least one patient during its lifespan, but was never given to any patient, subsequently expired and was discarded. Per national standard, when a blood product is ordered, it is removed from the general blood product pool. The product is reserved for a specific patient for 72 hours, and that's unless the provider tells the blood bank to release a product back to the general pool. The average cost for a blood product for blood product wastage in our hospital ranges from approximately $5,000 to $10,000 per month. A significant proportion of blood product waste is due to blood products which are ordered but not given. Approximately 25 to 30% of blood products dispensed in our hospital are ultimately returned without being given. Not surprisingly, the OR is the department responsible for the majority of returned blood products. So our problem, continuing on with this, is that currently there is no order in our EMR to communicate directly to the blood bank to release the blood being held. And furthermore, there's a lack of awareness among surgical and anesthesia team members to this issue. Our hypothesis is that products undergoing a 3-day hold from an OR type and cross are more likely to be discarded due to expiration instead of being transfused during their lifespan. Our smart aim is to reduce the number of ordered, not given blood products wasted by releasing blood products immediately, post-operatively in the PACU. Our planned intervention: add an order to cancel type and cross product within the PACU post-op order set to authorize the blood bank to return type and cross blood products back to the general blood bank pool. This would exclude patients with known antibodies, those with massive transfusion protocol initiated liver transplants, etc. Blood product waste will be monitored before and after the implementation of the proposed change, and education will be provided to the various stakeholders involved.
So in regards to the literature review, the only thing that would remotely support our hypothesis was this article put out in 2006, where there was a partnership in the UK that collects data looking at blood management and inventory practice. They put out a survey to try to identify examples of best practice in terms of managing a hospital stock level and minimizing the wastage. Among a few other things, they primarily looked at measuring the issuable stock index, which is really the number of days of unreserved stock held in inventory, and wastage as a percentage. And they addressed in this article that essentially was primarily due to expiration or issues with temperature control. The data that they were able to collect from these hospitals they found was suggestive that if individual hospital kept the issuable stock index to a minimum, that this may reduce wastage overall. And most related to our project specifically is that the data that they collected was notable that keeping a cross-match reservation to a 24-hour period rather than a 48-hour period meant that more blood was spent time in the stock, which increased the opportunity for it to be used, furthermore decreasing the need to order more blood into their health system. Overall, this was identified in this article as a potential best practice if a hospital wanted to reduce the stock holding and wastage seen. Oh, I'm sorry. I'll finish this. Sorry, guys. So as far as the stakeholders that we identified, number one was the blood bank. Number two is the anesthesia and surgical department. Blood is a scarce resource, so certainly blood donors are part of that as well. Hospital administration, and what we didn't realize when we undertook this project is really the IT department was active stakeholder involved as well.
So this is a process map that I really enjoyed creating. I pulled it from the Lean Six Sigma methodology for quality improvement. I think the power of this particular type or format of process map comes from its ready visual representation of the areas of improvement. So I'll draw your attention to the red Kaiser burst that kind of, again, really well visually highlight the areas of improvement that my fellow residents have pointed out before, including that, often the surgical residents or the anesthesia team will order both a type and cross as well as a cross match, that in general there's some degree of misunderstanding of how the blood banking process works. And then, in the morning, preoperatively, the nursing staff will often just routinely draw 2 type and screen samples when often only one is needed. And that low transfusion risk patients are often cross-matched when really only a type and screen is truly necessary. And then, as we were working on, there's no current EPIC order set available to optimize then releasing those blood products when the surgery is over. The blue bubbles are kind of the positive areas, and then as you see, that red triangle is just an area of delay.
So we kind of used a lot of the lean terminology here to help identify where we could tackle this problem. And the waste that we found was involved with this is one, was a defect in an inability to cancel type and cross orders, an overproduction of the type and cross orders by not understanding the appropriate amount of blood products to order, the holding of the blood products for 72 hours, and then a very convoluted process for being able to cancel those orders currently. Our fishbone diagram kind of helps detail this out as well. To keep this short and sweet, the machine section is the section that talks about either the technology that was involved that became an issue for us, and that was being able to communicate with the blood bank through EPIC. The method section is the fact that blood is held for 72 hours, which is a national standard, but that was the thing that we wanted to try to intervene on. The material piece of this is blood products. They're a scarce resource, and we want to utilize those. And then the last two pieces were the manpower, so the ordering of blood products again. And then the last piece that we found was a intervention or a possible root cause for this is the lack of understanding, the lack of knowledge about how many blood products are wasted.
So the PDSA cycle, so we set out to create a post-operative order set. We wanted to kind of make it a pilot study. We had stakeholders that we discussed, co-sponsors, and everybody was in agreement. The only department at present is the EPIC approval. To kind of put in perspective, it's kind of like on the governor's desk. One of the senior chief executives of EPIC is actually looking at it right now, and they just have to approve it someday. We're hoping to analyze 2 to 3 month data to see how much blood products actually being, the reduction in the amount of blood product that's being ordered and not used and sitting on the shelf. For a specific patient. So we've coordinated with the surgical team, the blood bank, and anesthesia. Once this order set comes out, we hope to actually have lectures for the surgery and anesthesia department, which is there to allow for people to understand what this order set will do and the safety stops within it. So far, we're pretty optimistic about this because after we completed a survey, this is kind of what we've learned. We've sent out about 4 questions. Question number 1 was basically which department do you belong to? Question number 2 was regarding are you aware that that we keep blood products for about 72 hours? And it looks like at a surgery and us, most of us were not aware that we have a sort of a 3-day holding period. 4 is, they're all on here. 4 was about whether people think that this will make a difference, and most people actually said yes. And how do I go back on this so that everybody can actually look? So yes, and then 5 was whether people will be comfortable with this implementation, and mostly people actually were. Then what we've learned is that not only is the surgery and anesthesia department not aware of this about blood products, but we also learned that mostly the blood products that we do order, anesthesia on medium 33%. They estimate that 33% of the time they actually transfuse, then surgery about 20%. That kind of says maybe surgery is a little more optimistic in terms of how much blood they lose. So for future direction, so we want to add this to the PACU order set. This would exclude specific patients with antibodies, high-risk patients that are going into the ICU, liver transplant, or potentially patients that already received some blood products during the intraoperative period. We will have blood bank monitor these numbers. They're already doing this. They have databases seeing how much blood product is ordered, how much is being used, and how much is being wasted at the end of the month, as well as inventory and the cost of the inventory. And kind of mentioned that once we've implemented this order set or before, we hope to educate the different departments about how it's going to work. Any questions?
You mentioned that there's a 72-hour holding period for these blood products. Is there any data available on how many of these patients actually get transfused in the 72 hours post-operatively? How many of those blood products are actually used?
we don't have a good sense of that information, but that was a conversation that we had with our surgical stakeholders as well. One of the concerns we had was, were these going to be blood products that were going to be not available to these patients afterwards? They felt like there wasn't a high utilization of those blood products. And another aspect that we thought of to minimize the risk to the patients were patients that had any antibodies in their screens would stick to the standard 72 hours. So anyone else should already be available for an electronic cross-match and have blood products readily available. So we thought that minimized any of those risks.
For this order set, is the box going to be checked or unchecked to start?
Yeah, go ahead.
So after much deliberation on that topic specifically, we decided to go with it unchecked. Due to the fact that, too many people just like go through the pack order set and kind of breeze through and click what they already know. That would make the education on this, I think, a lot more important because you don't have that automatically happening. But I think from a patient safety standpoint, I think if people didn't get the education ahead of time, there could be some unhappy patients and providers if they didn't realize that was happening in the background.
You were to kind of self-select most of those patients out, right? So you're not typically putting in regular pack orders, even for liver transplant patients.
Right.
You're not putting the order set in for ICU patients. So really the only population that you're concerned about is patients with pre-existing illnesses.
Primarily.
Jason?
Hard stop with what? Sorry.
Within the order set, creating a hard stop rather than having a check or uncheck, just have it unchecked.
Oh, where you have to go through? Yeah. That's an option as well. Other questions?
Just have a quick one. Can you tell me again what your definition of waste is? Is it ordered and not used, or ordered and not used and gets thrown away because it expired?
So, ordered but not given specifically refers to those blood products that are ordered at some point and are tied to one patient at one point in their life cycle, and then ultimately make it to the end of their expiration date and are thrown out.
Okay, so it's not.
It's different than any other type of waste.
You know that the waste that the numbers that you showed in your pre-intervention.
Right.
Those are all specifically surgical wasted, or those are other areas? Do you know that your problem is your problem?
Yeah, so I think I'd pull that back up. Yeah.
That would be
Yeah. So you can see this is like the breakdown of all the different departments. One of them stands out a little bit. It's us in the OR, which kind of makes sense. I mean, almost every other department in the hospital, when they're ordering blood, they're giving it immediately. We're one of the few places that's ordering it to kind of have it on standby. But yeah.
I guess my question comes from this says percent returned. Do you know the percentage of those that were actually thrown away because they were past their
So specifically from those, you mean? So this is our breakdown of like the types of waste. So purple is our intervention that we're going after. So that's the ordered, not given. The green bar, which is big for the plasma there, is any type of damage that's actually done to the plasma products just in the process of thawing them out. That's a big component of our waste here in the hospital. Red's returned due to temperature difficulties. And then the blue is out of the blood bank for too long. So those are kind of the other components of it.
All right, thank you for that lovely presentation. Our next group is going to be presenting on medication allergies.
Hi, everyone. I had the pleasure of introducing our QI project on allergies. So our question that we were trying to address was how to prevent a patient from getting a medication that they're allergic to in the preoperative setting, or in the perioperative setting, excuse me, and that includes us. And so using a medication on an allergy list can lead to a multitude of adverse effects, including safety issues. There's a variety of those, ranging from mild or just side effects to life-threatening safety issues, prolonged hospital stays, and patient dissatisfaction. But not all allergies are true allergies. Some of them are side effects, and we'll kind of go over the spectrum of this a little bit. Some of them are side effects, some of them are just intolerances, and some of them are true allergies. So mislabeling of a drug allergy may result in a couple of things: unnecessary avoidance of an effective drug, giving a second-line therapy, which may be either less effective or more expensive, and then may potentially lead to higher rates of adverse effects. So in determining whether we can give a medication that a patient has a quote-unquote allergy to, we look at a couple of different things. So adverse drug reactions, we look at severity, ranging from anaphylaxis to a minor side effect. The timeline, is it a history of or is it a current adverse drug reaction? And then any other associated factors during that event. And so that all leads us to our clinical decision of whether to use a medication or cease its use. Looking at the difference between intolerances and allergies. So starting with allergies, as we all know, there are immune reactions. Prior exposure is required, and it may involve a rash, angioedema, or anaphylaxis, amongst a couple other reactions. Whereas an intolerance is usually a pharmacologic reaction, and then can include plus or minus susceptibility. So they're also usually common or well-recognized reactions, and they may be dose-dependent. The risk of adverse drug reactions for intolerances is usually low, but not negligible. And then adverse drug reactions could occur, but the reaction is unlikely to be dangerous. We may be able to treat the side effects or reactions with other medications, and we may minimize reactions by altering the drug dose or formulation. However, health professionals in general often do not provide sufficient information on the EMR regarding reactions, or may misclassify reactions altogether, which is kind of where our intervention comes in. And this, Justice made this slide. I'm not this clever. But a few commonly mislabeled items, just for some humor: dolphin as fish, tomatoes as vegetable, DO, chiropractor, orthopedist, dinosaur observer, anesthesiologist, a few fun ones, just the ones that put you to sleep, and true drug allergies. I'm allergic to alcohol. When I have too much, I black out. Epinephrine, it made my heart race. Benzos and opioids, they made me feel funny. I must be allergic. Those are all wrong, by the way.
So these are a fishbone diagram. And as you can see, there are so many factors that can actually lead to allergies being misclassified or even not being specified or mislabeled. Patient factors like not knowing exactly what the allergies are, or even arriving late in the pre-op checking area and not giving enough time to the nurses to check it to update the allergies. Individual factors with the staff. It's a stressful environment preoperatively, and time is a big, huge factor. So there might not be time to update the allergies. And the task, it requires an extra step in EPIC to update them. It's not a one-button click. Team factors, like there are so many teams involved. Everybody is supposed to be updating the allergies, and people will feel like, oh, the pre-op nurses have already updated them, so I don't have to do it, or the PCP will update it and such, so end up not being updated. Education factors, people not realizing what's the difference between what is a true allergy and what is an intolerance, and that can lead to allergies not being updated. Computers not working in the pre-op area, or people having multiple tasks to do. And then it's preoperative time is usually the stressful time and environment. So all those stressors can contribute to allergies not being updated.
So we decided our hypothesis was nice and long. We thought by educating the pre-op nurses who always go through the allergies, we would be able to address our patients saying that they have allergies to benzos and opioids. And by addressing it then, we might reduce them being misclassified as allergies and ultimately improve patient satisfaction knowing that they aren't getting something that they're actually allergic to. So what we did was we reviewed a week of OR cases and looked at everyone and all the cases and found out who listed allergies to opioids and benzos and how they were classified with severity, intolerance, and versus allergy and then reaction type. We met with allergists to create a reference sheet that we could provide the pre-op nurses so they could go over. And then we talked with the pre-op charge nurse to see if every morning rounds that they go through to make sure they're reminding the nurses to go through these allergies and make sure they're filling out the entirety of the form. So that's what our little cheat sheet looked like that we put in all the bays. So it kind of goes through the opioids and the benzos, opioids on top, what an allergy really is versus intolerance like nausea, vomiting, having itchiness, and the same with benzos. And it was kind of when they go through it to remind the patients that if it is a true intolerance, let them know that there's a chance they might actually receive it.
Great. And then Glenn and I are going to talk about the results, basically from the intervention that Kaylee described, to post. So I think this is sort of our table one, the demographics. We did 972 cases in total. And, I think what's interesting to note is that 19% of all the patients who came through the OR had an allergy listed, whether or not it was a true allergy, on their allergy list was a benzo or an opioid. So I think that kind of underscores there's a high prevalence where we can either correctly identify an allergy or take an allergy off the allergy list that a patient can then get. And of those 19% of patients who are in the number of allergies here, 96% of those had opioid allergies. Very rare that we saw patients who had benzos listed as an allergy. And just anecdotally, like oxycodone, Vicodin, just having done the chart review, and codeine was also very common in there. So pre-intervention, so on the left here, just looking, this is also just to basically state that we did 513 cases pre-intervention, 459 cases post-intervention. The number of allergies were largely constant, and the percent of opioid allergies were largely constant. So just again, our table one to show that pre and post, essentially we're dealing with the same substrate.
So then looking at the percent of specifically unspecified allergies, and that included basically having an allergy listed and then not specifying whether it was an allergy or an intolerance. Pre and post intervention, 58% were unspecified pre-intervention, and then we dropped it down to 46% unspecified post-intervention. And then if you look at the percent of correctly identified allergies, so this is the pre-op nurses identifying an allergy that's truly an allergy or an intolerance that's truly an intolerance, it went from 29% pre-intervention to 37% post-intervention. The percent of incorrectly identified allergies, so this is either an allergy that's listed as an intolerance or an intolerance that's listed as an allergy, increased just slightly, but not very significantly, from 13% to 16% pre- and post-intervention.
All right, so the goals of our project was to educate the preoperative nursing staff as they're the first line of contact for patients coming into the OR. And our project basically stemmed from a patient's getting medications and then reporting it in PACU that they got a medication they were allergic to. So we used the pre-op nursing staff to differentiate an allergy from intolerance. and educate the patient on what the difference is and then correctly document as such. This would lower reports of patients receiving medications they're allergic to in the perioperative period and could possibly raise patient satisfaction. So in our pre-op intervention and post-op intervention data, similar numbers of reported allergies to opioids and benzos were reported. Similar distribution between the two compared pre-intervention versus post-intervention. So what changed? 58% of the pre-intervention versus 46% of the post-intervention allergies were labeled as unspecified as far as their severity and type. So we had more allergies that were actually labeled. 37% post-intervention versus 29% of allergies were correctly labeled. So we had an improvement in them being correctly labeled. But we did have also an increase in incorrectly labeled allergies, but there was a smaller difference in the two. So we made an improvement in what was actually labeled and reported. Overall, the nursing staff demonstrated improved understanding in categorizing the allergies and educating the patients. So some of the take-home points from our project: there continues to be a misunderstanding on allergies, what's a true allergy from an intolerance or side effect. Patient education and education of all staff involved in patient care is important to provide safe care for patients, optimize patient care, and to drive patient satisfaction, as that's a big player in medicine anymore. And then standardizing the way allergies are categorized will reduce the number of these reports. So together we can improve patient satisfaction. We felt like we made a dent, but there's still work to go. Any questions about anything?
Did the group consider doing a pre and post test, knowledge test for the nursing staff to kind of show whether or not this handout and education that you provided them had an impact on their ability to perform a test?
We didn't go into like a knowledge test for the nursing staff, but we talked about patient satisfaction pre and post-op, which is something to consider. But I think that'd be a good way to go in the overall picture as far as educating the nurses. We actually went to the huddles in the morning, handed out the little form, the education sheet, and then discussed with them our project, what we're aiming for, and if anybody had any questions, they had that form in their bay so they could use it as a reference to educating patients.
When you were developing the project, did you have any nurses at the table with you that were identifying barriers, issues that they had? Who was actually sitting kind of at that project?
Yeah, so I happened to be on APS while we were doing that, so I was in close proximity to a lot of the pre-op nurses. But yeah, I mean, we didn't formally sit down with any nurse stakeholders, but at a more informal level, we're certainly like learning what their process was, proposing, okay, this is what we're thinking. Would that interrupt your flow every day? And that was, I guess, more informally, but it helped us figure out what would be a reasonable, first PDSA cycle to figure out this is the reasonable intervention that wouldn't overload the nursing staff in the morning, because we figured it was part of their process, but it is a little bit more nuanced to figure out what's an allergy versus not. So that's kind of where we honed in.
So actually, at the initial stages, when we are thinking about the allergies, we identified the stakeholders, who were the pharmacists, nurses, surgical team, and the anesthesia. And we are targeting all the different perioperative areas, OB, EOP, inpatient OR. But then we actually narrowed down. So the initial information we gathered was based on talking to different stakeholders before narrowing down to the preoperative nurses in the ARP or OR.
We thought about that, but I think it's hard to really go through and figure out if something was changed at that time or not. But we thought about it.
If you wanted to take this a step further, is there another leverage point that you would focus on? Would you try to beef up your education? Would you try to tackle this from a different perspective? How would you improve the numbers if you say do this project again next year?
One of the things we thought about was that not all, very much not many, but of the patients who go through pre-op clinic, that's another place where there's a very, dedicated time to do a med rec and go through that. So that would be a very, deliberate time to do that. Or other things that was like another very clear access point to where the allergy list is accessed and could be remedied.
I think the patient satisfaction component was maybe what drove this project in the first place, and I think that might be an area to focus on moving forward, but more difficult.
All right, thank you guys. All right, so our next group is going to come and present on emergency room to anesthesia handoffs.
Sweet. See if I can get it outside. Okay, so for our project, we decided to take a look at trying to improve the process of communication and throughput for patients who are basically arriving to the perioperative area urgently but not emergently, i.e. in sort of a trauma situation. So when a little bit more time is available to us in order to sort of parse out what's going on with patients and try to make that process a little bit more smooth. So this is just this is our SMART aim here. So our goal was to improve the communication between the primary sort of surgery team or ED providers and the perioperative teams for urgent cases from its current state to where it is now to a more organized system, which we'd be able to measure through serial survey, basically satisfaction of the stakeholders involved in the process. So specifically, we'd want to improve the handoff between the primary service and the OR in-room providers for non-emergent add-on cases, as we've already discussed a little bit. We wanted to, by making this measurable, we would survey the stakeholders before and after implementing a change in provider-to-provider communication. We would examine multiple options for implementation for our intervention and discover current system processes and try to identify areas that could be improved. We would try to keep our aim as narrow as possible in order to try to sort of stay in our lane, so to speak, and try to make sure that we're doing things that are specific to our goal and not to goals of other people who are also, actively pursuing other projects, and also try to make a change that's sort of requires very little but maybe has a high impact and can become maybe more ubiquitous in the future, and sort of maybe even at some point taken for granted as something that is just done in the culture. And then that's basically what is listed in the timely portion. So look at the current system after interviewing some stakeholders involving ED providers, ED nurses, surgical consultants, and then as well as operative nurses, charge nurses, pre-op nurses, and then anesthesiologists, mid-levels, and residents. These are some of the things that we identified as sort of the flow for a patient who arrives in the emergency department is ultimately evaluated by, consultant surgery service. It's determined that they need surgery at some point in the next 2 to 4 hours, something like that. This is what we determined. 2 to 4 hours would be sort of our urgent but not emergent sort of time frame. And this is essentially the process that we identified in order to try to seek improvement. Here is a sort of a process map that we put together. The flow of essentially sort of as the patient progresses through this experience. And so as the patient arrives in the emergency department, they're evaluated by the ED staff, ED team. Consult to surgical team is placed. The surgical team decides whether the patient is going to need surgery and how urgently they would need it. If they need it soon, then the consulting provider completes the case request, informs the ED provider that surgery is needed, and then the ED provider asks the unit clerk in the emergency department to inform the OR charge desk that this needs to be sent to, the case request needs to be added essentially to our onboard list that we see in the at the OR desk area. The ED nurse contacts the pre-op nurse for sign out, and then our nursing charge contacts us with the details that there's going to be a case and some of the sort of rudimentary details of what that case will be. At the same time, as the patient arrives to the pre-op area, she or he begins to be evaluated. Consents are obtained, pre-op orders are done, and then the determination is made essentially by us at that point whether they meet criteria for safe delivery of anesthesia within that time frame. If so, then and everything looks like it's appropriate, then obviously the case proceeds as usual, as normal. But if not, then the determination needs to be made whether surgical concerns are essentially more detrimental to the patient than what the anesthetic risks could be in maybe a patient who is potentially a high-risk patient. And if that's not the case, of course, then we would have to sort of go through the process again, determine when the best time for surgery would be for this patient, and then sort of go through the process once again after maybe further workup or evaluation had been completed.
So again, our problem was surrounding what seems to be the ever-growing list of add-ons, especially in the middle of the night in the main OR. Oftentimes when these cases are listed, the only thing that we might know right off the bat is name, MRN, age, and what surgery they think they want to do. And I think everybody has felt at one time or another that this has led to some delays or some frustration in getting to the operating room. So would it be possible to facilitate some type of communication between the anesthesia and surgical teams in order to minimize delay and especially frustration getting to the operating room? So just looking at some of the contributing factors, as far as patients are concerned, a lot of times, if it's urgent, inappropriate NPO status, if they're non-English speaking, this prolongs consents and can make things a little more confusing. Allergies, and then past medical history may not be complete, especially depending on how many times they've been through our system. We may not know that much about them. As far as supplies, just in general setting up the OR, what am I going to need? And then if it's the middle of the night, is there anybody to help? Especially with more complicated setups. As far as the task was concerned, like I mentioned, depending on how many times they've been through our system, we may not be able to view their H&P if it hasn't been signed. Their radiology reports may not be read. And the surgical team may be off doing something else and isn't available to chat with us about it. As far as education, I think just a learning environment can be difficult to establish in some of these more urgent cases. As far as individual staff factors, we may be dealing with limited staff at night, especially after hours. And then for working conditions, pretty importantly, it can be a high acuity, stressful OR. It can be noisy and rushed depending on how the patient is doing. And you may be dealing with multiple fatigued people. Regarding communication, again, I don't have any direct contact numbers a lot of times with some of these tax teams. We may have pager numbers, but it can be difficult to get those pages returned occasionally. And it would be nice to have a documented area about what has been done with the patient so far. What antibiotics have they received? What product have they received? What has their course been? And then otherwise, we may see miscommunication and delays to the operating room.
Just to kind of go over some of the basics of our PDSA cycle, we basically went through one cycle and are kind of in process of another. So I'll kind of talk about both. But obviously the plan was to improve handoff between primarily the surgical team and the anesthesia team, including the in-room provider. And so the way we set out to do this was to essentially identify some of the most important factors and pieces of information that we wanted to be relayed to our anesthesia teams. In doing so, to try to avoid some time-consuming work and basically some extra work for the surgical intern and so forth. So on the do step, basically was to describe some interventions carried through with those on kind of along the process map that Ken was going over. And I set off to do a few of those. One is still kind of in process. It's mostly an Epic change, which I'll kind of talk about. But ultimately what we ended up doing was gathering input from all of the anesthesia providers and seeing what the 5 most important things or pieces of information to gather from the surgical team before the case would be. So that was our primary study step, was to identify those 5 factors so that we could act on those with a change in Epic. And we thought that kind of paring things down and just narrowing down the scope of the information that they would have to hand off would kind of streamline things and be less time consuming for them. So basically what we've done in terms of the ACT step is to begin the process of making a change in the case request booking in Epic. It hasn't been completed yet, but it looks to be in process still. We actually got an email about it back today. But basically what the step would be to have a line within the case request booking to provide a direct contact number. So if the person who's putting in the case request info is sitting at a computer in the ED or something like that, we could just call them right on that phone and get 5 pieces of information from them. And so we'll kind of go over the findings of this study. But basically the steps we've taken were to narrow down the focus of handoff to a few different kind of most important clinical factors that we wanted to know, and then have gone through the process since basically the winter to make this Epic change, which we hope will come into to effect fairly soon. And so the next steps would be to make the Epic change and then basically decide on the most efficient strategy for the actual handoff to occur between surgery and anesthesia, whether that's a direct phone call with the case booking or whether the information that we want from that just goes right into Epic. And then to try to quantify the problem in terms of, does it speed up ED to OR time? Does it result in less case delays? Is there a better kind of point of satisfaction with the anesthesia teams in terms of being able to tailor their plan in the OR? And then also a big priority would be to promote kind of buy-in from the tax team.
So the first step we took with our survey was to determine how many people in the department had had an unsatisfactory or concerning handoff from the surgical team regarding an urgent but non-emergent case. And it looks like about 70% of the department or of our responders said that they did have an experience like that. The remainder of our survey asked our responders to identify 5 items regarding the patient or the case that they wanted to hear first when they were receiving handoff from the surgical team. We had quite a variation in our responses, but our top 5 pieces of information that our responders wanted to hear were patient diagnosis, the procedure that was planned, significant medical and surgical history, access, and anticipated blood loss.
Okay. And so in terms of these were all sort of things that we had considered, things that we're considering it still for the future, but as we had mentioned before, we do have already kind of have identified and are going down the process of trying to make a change with the case request process. But these were all things that we identified as places that could potentially still have areas for improvement. And potential solutions as well. Some of these seem more viable than others. A lot of them involve asking people to remember to do more things than maybe they would need to be able to do or that they would want to do. And so that's the reason why we're looking for something that would sort of be within the system that all of us sort of use and live by, which is, the central Epic system, which we all visit, multiple tens and 20s, hundreds of times a week probably. And it's the way that we essentially communicate with each other outside of direct phone calls. And so it was the way that we decided was maybe the most efficient way to go through with this. And so in the future, if this project were to be carried forward, once the change is made through the case request process, phone numbers are added to that case request panel. We're able to sort of directly contact the person who made the original request anyway, which, granted, sometimes might be an intern and that person might not know exactly what we want to know. But in an ideal situation, the person who's making the request is also the person who had originally sort of consulted on the case and has, at that point in time, the most information that they would have for that patient because it's fresh in their memory and they're actively filling out the case request. It turns out this case request form is within a portion of Epic that the surgeons, the procedural teams have access to, where they're able to write what kind of case it's going to be, what kind of extra equipment they might need, and they're able to add, there's some comment areas. And so our idea as we're working with Epic is to try to essentially get just another text box added near the comment section for them to be required to add a contact number, whether that's a 4-digit pager or whether that's a cell phone or whether that's whatever it is. And so this is essentially going to, on here would be number 2 is what we're looking for. I think that's all we got. Questions?
Excellent project that has those patient safety for better communication. You identified one of the challenges, and that's stakeholder buy-in that is interdepartmental. Have you had a chance to talk to some of the tax surgery teams to find out what method that they prefer on communication?
Well, that's the process by which we identified kind of how they make the case requests. Was basically I just went and interviewed a few of the mid-level providers on the tax team, because those would be the people essentially that we were really targeting initially, because those are feel like the people who have dedicated ORs overnight and people that we see quite frequently and stuff. So with talking to them, we went through a few questions with them. Would having a reminder when the case request is open to call us be more useful, or would having a form to fill out and provide to us be more useful? And essentially going through a lot of these questions, it sort of became apparent to me that it'd probably be more onerous for them to carry around a piece of paper and probably not as environmentally considerate. So we decided to just have something that would be something that they already do, and it wouldn't really change very much their culture of the way that they do things. It wouldn't be, we could send out a reminder email, but essentially that box would just kind of be there once Epic was updated, and they could get an indication that that's happened. But beyond that, it wouldn't be like a new process that they would need to learn or to try to adapt over a short period of time.
Take it off my judging hat and more just kind of as a recommendation. One thing you could look into is whether or not that box, if it allows dot phrases, then you don't have to wait for a new box or something. You have to be able to create a dot phrase, work with the surgeons on it, say like, all right, what are the things that you usually want to have in this comment section? And just somewhere in there have anesthesia content, whatever that is, just a dot phrase. That way you're not turning gray waiting for it to make
Yeah.
an additional box that you can sort of form.
Okay.
But I think it's everything.
Yeah, so you said we could potentially just add a dot phrase into the comments section with maybe giving them access to our contact information, and potentially I even think we could put yes or no answers or leave, the triple star sections for those 5 most important questions that we've identified that we would want to know about the patient. We could put as a dot phrase to add into that section as well, potentially.
All right, so our next group is going to be presenting on the communication between trauma surgeons and the anesthesia team. No, you're not. Nah. They're going to do their own thing.
That's the last project presented today.
Okay. You guys have yours.
Preoperative communication.
Oh, preoperative.
It's very different than what you said.
Okay.
Okay, yeah, so we're going to be talking a little bit more about sort of global effective preoperative communication. Let's see if I can nail this. Okay, so this is a situation that happened to me. It's pretty accurately based on a true story. Basically, you have a case, they're going to get a partial nephrectomy. It's booked as partial nephrectomy with IVC thrombectomy with this doctor, get her done. And so your plan is to do general, second IV, and epidural. It's going to probably be supine. They'll probably give Ansef. Expected blood loss is a little more than they say it is at the end of the case. They didn't order anything. The anticipated case length is like an hour longer than they booked it for. And I don't think I need any special equipment. So you bring the patient back and they're like, no, this is a total nephrectomy with IVC thrombectomy and IVC reconstruction, possible kidney reimplant. He only has 1 kidney. Is Lyman here? This was our case. Dr. Slow and Bleedy. We are not doing an epidural. No way. You need a central line and a dialysis line. Cool. So we did, you need bilateral sticks. It's going to be like a sloppy lateral versus prone, whatever that means. We need these antibiotics. This is going to be like a liver transplant. You're going to lose about 4 blood volumes. We've got some in the room, but you should probably do an MTP. We actually ended up doing a catastrophic transfusion protocol for this patient. We have no idea how long this is going to take. It's going to be a while. And we're going to need, you probably want this stuff. That's literally what I brought to the room. And this was like 15 minutes before a case rolled back. I was like, how could you not know this, dude? This is what they're looking at you like, and you're like, how could I not know? What are you thinking? I didn't know. Why could I not know? Wait, I'm not a mind reader. Wait, I didn't even know who to ask. You weren't even around. Where am I? How did I start to fix this? And then, then you kind of come back and you say, well, how could this actually have been prevented?
That's going to be awfully tough to top here. So obviously preoperative miscommunication is a big deal, and you don't need just that case to tell you why. You guys have all probably experienced that, to where things as minor as, throwing in an A line unexpectedly, to having the wrong antibiotic, to having equipment that is not readily available, and then therefore delaying the case. So obviously we know it's a big issue. It is also a significant contributor of perioperative adverse patient events. based on the research that we had looked at, the numbers are kind of a little all over the place, but around 38% of perioperative communication errors occur in the preoperative period. Excuse me. Some of the major categories of communication failures include poor timing, incorrect information, unresolved issues, and then wrong or missing individuals. So, when we're all sitting there talking with the circulating nurses and discussing the upcoming case, and there's missing members from the surgical team, the residents out there, the attending hasn't been seen all day, and things of that sort. So, from a preoperative communication standpoint, fewer adverse surgical events. Stakeholders all agree that communication is important, and just a matter of how do we best accomplish this. The optimal timing for preoperative communication is the day prior to surgery. That's wishful thinking. We do have patients that go to the preoperative clinic to get optimized for surgery. However, even when they do end up going to the clinic, there tends to be some miscommunication between those working in the clinic and then the attending from an anesthesia standpoint that day, and also things that have not been appropriately communicated to the surgical team as well. And then also, preoperative briefings increase on-time surgical starts, which is obviously what we're all interested in here at the university. So the global aim, is better preoperative communication among OR providers to improve perioperative patient safety. And that's a pretty broad aim. It's the global aim, but to accomplish that, in an ideal world, we'd have some sort of automated, standardized system in Epic that easily identifies certain things and can communicate certain things to everyone as part of that operative team, such as the surgeons, the OR nurses, pre-op nurses, anesthesia team. But more realistic is developing some sort of simple, standardized, straightforward preoperative system that conveys this efficiently to other team members. Oops. So, why is this so hard? There are a number of different things, but I think the common things that come to mind are there is a lack of a standardized method. We haven't really found very many standardized methods done at other institutions that do this effectively. There are time constraints. There's financial constraints. Not everyone is fit to go to a preoperative clinic, preoperative anesthesia clinic. And there's also difficulty in finding all care team members, kind of as what I was discussing earlier, is that we could be discussing this with the team in the operating room, the nursing team, but no representative from the surgery team, or they could be discussing it, and we're in the process of dropping the patient off in the PACU, getting ready for the next case.
Okay, so now it's PDSA time. This is the PDSA cycle, everyone. You may have seen it before. Okay. So the first plan was, here's our process map. It's sort of small font, but it's basically like everyone else's process map. We can just kind of step through all the things we've kind of already summarized. And then here's our fishbone. Here are identified different patient factors: medical knowledge, communication, personnel, staffing, equipment, environment, policy, procedures, etc. Essentially, this just helped us identify kind of things we've already talked about, which is basically that it's difficult finding these people, all the members of the team. It's difficult getting them all on the same page. It's difficult finding the time to do that, coordinating all the different patient factors in the way that we see them, the way the surgeons see them, the way the nurses see them, etc. And so what we did for an initial evaluation is I sent out just a few emails. You probably got a couple of them. We sent them to all of the surgical departments, all the anesthesia department, anesthesia administration, all the peri-op nurses, the intraoperative nurses, just to get kind of an idea. And we got 244 responses, which I don't think was actually too bad. It was a good cross sort of all the different represented groups. So our results. So what is the role in preoperative care? We had most of the response from the surgery residents and the OR nurses, so great. Thanks. But they were involved and excited to participate. I mean, I think like attending surgeons were more than anesthesia residents. Oh, okay. How important is it to discuss each of these issues preoperatively? So need for blood products was the top most important. Positioning, GA versus MAC, and difficult airway. Those are sort of identified by all the different groups as the most important. And then some of the other things that people globally thought were important were antibiotics, projected blood loss, special equipment, and the placement of lines. Some of the things that people didn't feel that strongly about were a little surprising to me. Delays. One thing that we care a lot about that almost no one else did was PACU pain management. So when you're perseverating on whether or not to give Toradol, not a whole lot of other people care about that globally. And also best means of communicating. I thought that was nice. No one was bought into that. But in general, we try to focus on the things that people were excited about as areas where we could target. We asked about regional, but we didn't really go into it because as I think we all kind of know, is a big, hot topic between anesthesia and surgery. Would you be willing to participate in a timeout? A little over half of the people said yes. Quite a few people said no. So our first idea would be that everyone shows up in the pre-op area, does a quick little timeout before we go do the pre-induction timeout, before we do the pre-surgery timeout. People were surprisingly interested in this. I thought this was going to be a giveaway, but people were surprisingly okay with it. We thought that we had enough people say absolutely not, though, that we decided this would be too cumbersome. But if not, why not? Most people said, I just don't think there is time, and I think, anecdotally, we would all agree with that. I don't think there's a preoperative miscommunication issue was the least identified.
Yes, it is. So our smart aim, so all OR care team providers will directly communicate about antibiotics, blood products, positioning, special equipment, anesthetic plans, and airway concerns prior to patient transport to the OR in order to decrease the number of perioperative miscommunication events to less than 1% of elective cases by July 1 of 2019. So essentially, what we did was we focused primarily on elective cases, and it was primarily the urology teams, and to be honest with you, I forget, do we include ortho teams as well? So first case, elective ortho and urology teams, and what we did is we placed this very bright, obvious sheet in the pre-op bays, and we also communicated with the pre-op nurses that we were going to be doing this. And what it was is something very, very simple for the surgical team, as you can see at the top, to fill out, maybe 5 questions or so, kind of saying what antibiotics, estimated blood loss, and we gave very specific ranges: minimal, greater than 100 cc's, greater than 500 cc's, whether or not they were ordered, positioning, special equipment needs, and then from an anesthesia team standpoint, our plan: general, sedation, regional, any plan for additional lines, and any concern for airways. We did this for 2 months, and we actually had a pretty, I think what we think was a decent response. 49% of these forms were completed. There was a little bit of a, misunderstanding of who was supposed to fill these out when we did it for the first month. I don't think that, I think some of the anesthesia CRNAs or residents or AAs thought that the attendings were supposed to fill them out, and the attendings thought that the residents and CRNAs and so forth were supposed to fill them out. And so we didn't have really the greatest response, I think, that first month, but then the second month, once we communicated it with everyone once again, and then also the pre-op nurses, we had what seemed like a better response.
This is me re-emailing everyone.
Just a reminder.
With progressively more highlighting.
So kind of the next steps that we would take in this cycle, just continued provider education regarding preoperative care forms. You can do targeted education not only for nurses but everyone in the perioperative team. Could be a hard stop prior to OR transfer. We did discuss earlier if there's any interest in doing a timeout prior to going back to the operating room. You could expand this project to the AIP, AOP, all elective cases, not just limiting it to the first case, ortho and urology cases. There could be a follow-up survey, provider survey once we've achieved a 90% completion rate. and then also collecting some data regarding perioperative miscommunication events. So kind of just evaluating some data over a period of 3 months, 6 months, a year, and trying to identify how many of these events are actually related to simply miscommunication.
That's it. I'm just going to roll like credits. We're not thanking ourselves. Whatever. Did what work? Does PowerPoint? No, apparently not. That's all. Questions? Did our intervention work? I mean, so we haven't had a chance to evaluate our SMART aim, essentially. I think, very clearly our next steps would be to go back and re-educate our CA1. Spent many a time with the perioperative nurses, meeting at their huddles, trying to explain the form, trying to explain how much, they needed to be filled out, but it's another checkbox on the pre-op, thing for them, board for them. So I think we could either continue with better education or we could try a different intervention and try to get something done through EPIC. A hard stop through EPIC obviously forces everyone to do something. Something like when they fill out their interval H&P in the morning. But again, that's not the day before. It'd be ideal to have something the day before. I know, it wasn't terrible. But it's such an easy form.
And that was 50% of the forms that we got back were filled out. So it wasn't 50% of all of the first case starts for urology and ortho. Yeah. It was not that high.
Oh, Dr. Gillen, you have a question? Oh, okay.
Did you guys think about separating the forms at all? I mean, there's something that we all have to fill out in the morning. They have to have surgical consent. They have to have an anesthesia consent. Could you just staple it to the consent?
Yeah, I think you probably could have, but I don't really think it could have been made much easier.
It was on the
for them to see. Yeah.
It was like the front of the consent. It had we literally made it so you just had to circle it. They didn't even have to think about it. It was just circling.
Took me 4 seconds.
Wow.
Doesn't take very long.
I think we would like to do a better job of really meeting with the different departments and kind of explaining exactly how easy it is and what it is. I think the anesthesia department recognized it because, I don't know, they read all the emails. I got a lot of responses about it, but maybe try it with different departments. We felt like they were the most responsive departments, so yeah. Oh, yes, Dr. Gillen in the front row.
Do you feel like the surgeons are invested in this? I mean, we have survey stuff, but we don't always do what we say we do. I think
yeah.
we can kind of run into issues with, people say they're concerned about it, but you always figure it out, right?
Yeah, right. They're not invested. They're passionate about it when it goes poorly. Like their responses in the survey were like paragraphs long about these stories about how annoying it is that we don't know what antibiotics they want. And yet you're exactly right. When we were like, well, here's this really simple form, it didn't feel like we got as much of a response. So yes, I think that they recognize it as an issue, but I don't know. There's a lot of time constraint that just came up over and over again. I don't know how invested they are in actually.
I think the care just changes hands so many times prior to the patient coming in for an elective case that things, I guess to state the obvious, get miscommunicated because they'll be seen in the clinic from the surgical team, and then mid-level or resident will put in the pre-op orders for them. So they'll have an order for, let's say, ANSEF. Then we get in the room, we have the ANSEF taped to the bag or in our room already or whatever. And then we do our timeout right after everyone's draped and prepped and everything like that. And they go, well, antibiotics in, like, yeah, we're going to get 2 of ANSEF. And like, no, we want Clinda for this case. Then we have to call pharmacy if we don't have it in our cart. And they're wondering why Clinda isn't in within the next 10 seconds because we're not bolusing our 900 of Clinda. And so I think they're invested for that reason because they're invested that they don't want a longer delay than was already there. And that's just a small example, but
Yeah. Same thing happens with positioning. If you've ever been in a thoracic room, it's always yeah. I think you'd almost have to force the investment by just doing a hard stop at Epic. Would do things just like anyone who's been at Children's has done the Stuber score, and it's just click, 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 something like that before you can bring the patient back.
One of the biggest barriers we identified is that most of this information the attending knows, but it's not communicated to other providers that are putting in these orders, that are putting in the case request. And so figuring out how to make something simple and efficient that the attending can communicate that is hard.
And he or she is not always readily available. Oftentimes they're not coming in until either at timeout or right before timeout. Yeah.
Yeah, that's exactly what we're talking about. It's just as most of the teams know in here, getting something uploaded in Epic takes a couple of years, maybe. And so we kind of wanted to start with this form to just see how it went, but I do think we'll just have to force their hand and do something in Epic.
And the problem is that the person putting it in is not the attending.
Yes.
So
Right.
the resident's guessing, like, yeah, and Seth, minimal blood loss, because it's always minimal blood loss, like.
Or it's a scheduler who
Right.
has
I mean,
no
that's
idea.
exactly what happened to my IVC thrombectomy case. Somebody put that in, just as like a.
It's the same thing for case length too. Is oftentimes a scheduler scheduling it and saying that this case that was initially scheduled for an hour and a half turns out it's going to be 7 hours long, and they're going to be prone and turn 180 degrees. So surprisingly.
All right, I think our time's
My
up.
last question.
Oh.
Sure.
Do you think we're afraid to contact attending surgeons?
No, but I think, I don't think so, but I think that we kind of follow the usual climb the ladder as we normally would. It's first the person we end up contacting is the surgical resident, and oftentimes if it's in a bigger case, like one of the ONC cases or something like that, it's one of the senior residents, and they kind of have this mindset that, they're the one, they're the point person, and sometimes it's wrong, and sometimes we don't they don't clarify that with their attending, and we don't find out about that until shortly before incision or right at timeout.
I think the surgical residents are very intimidated to contact their attendings.
We love you guys.
I mean, we had this exact situation this morning where the surgical resident was refusing to contact the attending, even though we had contacted the attending, and the attending said no epidural. The resident was like, I'm not going to call my attending. We're like, well, we emailed him yesterday. So there's multiple points of miscommunication, obviously. Dr. Brainerd? Jason Brainerd?
What if we used that new secure chat function within Epic Haiku? It would put the onus, obviously, on you guys as our residents, but if you start a secure chat with that surgeon, it's all HIPAA protected, and ask specifically those questions, they could answer those questions from home, from their cell phone, from their office, et cetera, and you could get those answers back right away. You know, it's fine, obviously, from the attending surgeons, but I think their willingness might be, as long as you lower the bar for them and again, give them some ownership over it.
Yeah, that's a good idea.
Thank you very much.
All right, so we're going to move along here to our project, which is patient feedback and satisfaction scores. Here's the members of the group. So first we're going to start with a couple cases. So case one is a 53-year-old female getting a Whipple with Surgeon X. You do this thorough pre-op plan. You have all this, everything set up. You're going to do ERAS protocol, opioid-free. You're going to utilize the epidural throughout. Everything goes smoothly. You wake up the patient, drop them off in the PACU. They're still pretty sleepy. Can't really get too much of an assessment from the patient. And you do your handoff and you move on to the next case. Throughout the next case, you ask your attending, how's that patient doing? And they say, I haven't really had time to check, but I'm pretty sure they're doing great. Second patient, pretty much same scenario. However, this surgeon doesn't want to do any rest protocol. There's no epidural placed preoperatively. Pretty much just heavy SIVO and heavy narcotic. Again, the case goes pretty smooth. You wake them up, take the breathing tube out, take them to the PACU. They're doing okay. Can't really get much of an assessment. So you do your handoff, move on to the next patient. Attending, I haven't really had time to see them, but I'm pretty sure they're doing great. And that's kind of the frustrations of being an intraoperative care provider, is that you go through this thorough plan, but then you often don't get to see the fruits of your labor and see how your patients are actually doing. Currently, there's really no structured method of obtaining feedback for our completed anesthetics. All we have are post-op notes, which honestly are pretty useless. I mean, they all say PONV never present, but the actual incidence is about 30%. They all say pain well controlled, but you have no idea what it took to get to that. So we decided to try something to change that, which John will get into.
Yeah, so we'll be talking about our planning for the project, what we did, the results of our study, and what we kind of learned from this project and what we could potentially implement later. Where's the button? So our reasoning for our project, what we wanted to change was the amount of feedback residents were receiving from the PACU. Why change? Because we believe, and also studies have shown, that this can improve clinical practice and also build our confidence and our competence as anesthesia providers. And then how did we want to change what was happening? We were hoping to provide post-operative surveys to patients and then also to the PACU RNs. So the metrics that we wanted to measure was the communication with patients and nurses, post-operative nausea and vomiting, and then how our post-operative pain management was doing. So the design of our study, so what we did was we administered, based on the ASA Patient Satisfaction Initiative, which had several questions that they recommended patients receive. So we administered a survey, a paper survey, to patients who received general anesthesia